slide. So you're going to hear me make this point throughout the presentation today. You know, this would be an opportunity to engage this patient into the treatment, into care that she needs. So I do want to talk a little bit up front and then again at the end of my presentation about, you know, what services you could involve at different stages and how to. So first of all, you know, while this patient is admitted here at MUSC, we do have a consult liaison psychiatry service that should be consulted immediately. You do so by placing an order in Epic. And I have heard that they do also ask that the psychiatry resident on call is paged and the case is discussed, and they plan to see the patient within 24 hours. With buprenorphine patients or opioid patients, they do try to see the patient as soon as possible, but have up to 24 hours to see her. And just to let you know, they are able, if the patient is a good candidate and agrees, they are able to start buprenorphine while she is still admitted, which is absolutely fantastic. And then, of course, we have our outpatient clinic, our perinatal clinic that has specifically an opioid use disorder program within it, where the patient could then transfer into our care after discharge and continue with us if it was appropriate. And I will comment on that again at the end of my presentation. Next slide. So today I'm talking about acute withdrawal and how to manage that, and honestly, why to manage that in the inpatient setting. Just to remind you of the standard of care in terms of treating opioid use disorder in pregnancy, the guidelines are to treat with MAT, specifically buprenorphine, you know, or methadone, and that the standard is not to remove buprenorphine or methadone because she is pregnant. So when this last line says medication-assisted withdrawal is not recommended, I'm talking about taking someone who is engaged in treatment, taking them off of that treatment regimen simply because she is pregnant. What I'm talking about today when I talk about medications and withdrawal is a different situation. I'm talking about someone who's had, you know, recent illicit use and she is in acute withdrawal and not engaged in treatment. Next slide. So just to remind everyone or inform people who are not aware of what does opioid withdrawal look like, here are the lists of symptoms in the patient. It presents similarly whether male, female, pregnant or not. Unlike opioid withdrawal, unlike alcohol withdrawal or benzo withdrawal, opioid withdrawal is not technically fatal. It just feels like death. Very, very uncomfortable and can absolutely interfere with things like decision-making, interpersonal interactions, overall behaviors, overall sense of agitation, which, you know, we need to keep in mind when interacting. If you are in withdrawal and you are in pain, you are restless, you are irritable, it can be very easy for this patient to be perceived by staff as, quote, difficult, etc. So again, just a list of the opioid withdrawal symptoms. Next slide.
And Dr. Aujla, I'm so sorry to disrupt you, but just in case for people who are phoning in who might not have video, would you go ahead and just, could you recite that list?
Absolutely, and thank you for reminding me that some people are only listening. So opioid withdrawal symptoms: tachycardia, hypertension, muscle aches or muscle cramps, overall restlessness. This could be seen as like psychomotor agitation, legs sort of shifting around, overall can't sit still, anxiety or irritability, lacrimation, which is tearing from the eyes, rhinorrhea, which means runny nose, insomnia or difficulty sleeping, yawning, several symptoms of GI distress, nausea, vomiting, abdominal cramping, diarrhea, dilated pupils, and that goosebump skin. If you think about any substance, think about what occurs during intoxication. Withdrawal will be the opposite. Opioid intoxication is going to dry you up, constipation, right? And then the withdrawal is going to be the opposite, hence all of these fluids coming from the body. Next slide. So what do you actually do? You know, you've placed potentially your consult and you're waiting for the consult to arrive. You know, what do you do in the meantime? So, and I know this is something that the CL service here at MUSC mentioned, using the COWS rating scale. So the clinical opioid withdrawal scale, which will have the staff, you know, plug in what symptoms the patient is occurring, vital signs, that will indicate the severity of withdrawal, mild, moderate, severe, and specifically what sort of comfort medications you can give. So comfort medications or supportive care, not the same as doing a buprenorphine induction and getting that treatment, long-term treatment plan started. So what I have listed, and I will read it, is a list of what tends to be generally a standard of your list of medications that you can use to treat opioid withdrawal. And then when I move forward, I will talk about how this can be tapered for pregnancy. So I think, you know, and I have listed the top two here as, in my opinion, probably most important. First of all, let's get to the tachycardia and the blood pressure issue by using clonidine, or metoprolol is an option, especially if there's concern about compatibility of clonidine in pregnancy, which I'll address in the next slide. So starting with that, get that tachycardia down, get that blood pressure down. That will then also help with the overall sort of agitation, restlessness, which is going to be a huge win if you can get that under control. And getting her sleeping is really important. So some sleep aids that I've listed here, but not all inclusive. But what we tend to use sort of in psychiatry, what I've seen on different addictions units, trazodone, which is an antidepressant by nature, or Seroquel, which is an antipsychotic by nature. You know, if you have someone who you absolutely know, documented history of maybe bipolar, schizophrenia, Seroquel might be a better choice than an antidepressant. And then in terms of GI distress, you've got options like Ventyl, Imodium, Phenergan, for those muscle aches, Flexeril. And then for restlessness and anxiety, I've seen gabapentin on some standard protocols, but not all of them. So gabapentin, again, can help with that restless and anxiety. There's some literature that there's more use with gabapentin in alcohol withdrawal and not really a place in opioid withdrawal, but that is a potential option. Notice that none of these are opioids. We are not, you know, so this presentation is not about treating, you know, with MAT. This is comfort care while she's in withdrawal, and we are determining the plan whether to do, you know, to start MAT. Next slide. So this next slide here just comments on maybe some adjustments that might be made in the context of a pregnant woman. I want to make a disclaimer. I'm not an expert on all the up-to-date literature of, you know, the studies of clonidine in pregnancy, for example. My source for this page right here was ReproTalks. It's a great online resource that you can plug in any medication, and it will give you sort of an outline, a relatively up-to-date synopsis of animal studies, human studies, lactation, things like that. So clonidine is an option. There is apparently some mixed data on if there's any sort of long-term risk of behavioral effects in children. You know, the studies are more so in animal studies. The human studies are more so case reports and a little unclear regarding what other meds were on board or other factors that were not controlled when looking at outcomes. Overall, though, no increased risk for structural malformation at this point. You know, if you're coming across more data concerning for clonidine, metoprolol is an option. For sleep, again, trazodone and Seroquel are medications that we do find to be overall compatible in pregnancy. I never use the word safe with my patients. I talk about compatible, and it's always a conversation of risk versus benefit. And then for GI distress, hearing information from my OB colleagues, I've heard Imodium is lower down on the list of what you might use in pregnancy. Rather use a Bentyl or a Phenergan. And then going down to gabapentin, again, not always the standard to use, but if it is something that you are considering short-term for withdrawal, there are some animal studies showing potential for fetal growth and developmental impairment. And then Flexeril has some animal studies showing no increased risk for congenital anomalies. Again, my approach, and I think approach that's always good, is to target, start with the clonidine or metoprolol, get that blood pressure back into normal range, get that hypertension down. That will also help with the overall agitation. And then after that, focus on the specific symptoms that she's having, the specific withdrawal symptoms that she's having. It's not an all or nothing package. So if she's not having GI distress, then the Bentyl or Phenergan is just, PRN or does not need to be used. For me, the priority is, the clonidine or metoprolol and getting her sleeping, also because she could sleep through things like restlessness and agitation. Next slide. So if opioid withdrawal isn't fatal, why do we treat? I know that may seem like a silly question, but I think it's worth addressing. First of all, it's the standard of care. It's compassionate care. I've actually had a few moments in my training where I was shocked, where I was called in for a consult for opiate withdrawal in the ED, and a young man, and a staff sort of suggested to me that I didn't have to offer comfort care since it wasn't fatal. He could just sort of ride it out, which is not the standard of care. Why else? Because this is a critical moment in getting this woman engaged in the appropriate care, and therefore reducing and avoiding all the negative consequences of illicit opiate use. So this is the opportunity, especially once the restlessness and the agitation, the withdrawal is treated, that opens the window to having a really great discussion, non-judgmental, offering her education, talking about the treatment options. Motivational interviewing is a style of sort of interaction that we can use in sessions. It's a therapeutic approach, a behavioral approach, where we ask questions that are all about the patient's experience. Hey, what has helped you engage in care before? What have been the obstacles to you engaging in care? Oh, it's been fear. Let's talk about that. So it's more of a, hey, let's talk about what's helped you and what's been your obstacles, as opposed to the you should be doing this, you should be doing that approach. And again, if she is able to engage in this discussion, in a calm manner, a comfortable manner, it's an opportunity to get her engaged in care, including potentially getting buprenorphine on board while she is admitted. Also, let's not forget the nature of the disease. The disease, pushes the patient to use. And so we don't want to run the risk that the patient leaves AMA to use, or immediately after discharge goes to use. That might be in a situation where the withdrawal is not treated, there's no follow-up plan, or even if there is a follow-up plan but no bup on board, there's still risk of using opioids illicitly when she leaves and is waiting for her appointment, say, with our clinic. So want to be proactive about reducing that use as soon as the need is identified. So again, place that consult with the psychiatry service. And then remember our program, it's an outpatient clinic. We here at MUSC, we do offer buprenorphine, whether they're already on it or we can start it. And right now we're doing all patient care remotely. So really focusing on, increasing access to care. If you as a provider come across a woman who is pregnant, who has opioid use disorder, and you feel like she would benefit from our program, or you're just not sure and you want to get us on board, you, the provider, can call or text this number. The patient can call or text this number at any time. And once we get that text or that phone call, we fast track them into our care. They do not have to wait for a walk-in clinic, a walk-in appointment. They're seen essentially as soon as possible. And I'm happy to answer any questions, hear any feedback. Yeah.
Thank you so much, Dr. Aujla. Before we go to questions, and that was an excellent presentation. Before we go to questions, just wanted to let everyone know that another way to access care is to go to www.musc.care, which you see here on the slide. And there is a very simple thing to click on women's behavioral health screening. And it's just a series of simple questions that can be answered. And once that's submitted, that goes directly to the Women's Reproductive Behavioral Health Care Coordinator, who will be able to contact and reach out to the patient within about 24 to 48 hours, usually 24 hours. And the patient can fill this out inside your office as well. And as another note, very important, we are going to be returning for a special focus on updates on pregnancy during the COVID-19 pandemic. As you know, we are still in the midst of this time, and there has been some changes. And so Dr. Johnson and Dr. Campbell want to make sure everyone is abreast of the newest information coming out. And following that, our didactics will be on safety bundles. So we'll have a module on hypertension, a module on postpartum hemorrhage, a module on sepsis, and a module on diabetes.